Hello, good evening, everyone. I am Dr. Aman Khera, co-founder Care for Parents, and I welcome you all today to a very interesting, a very relevant, but probably a very not thought about topic. And that topic is about psychological well-being with a focus on the elderly. Why I'm saying not thought about is that because probably we do not think much about that. Now, before I start, I would like to ask a question to the audience here, and anybody can answer. I'll give you 30 seconds for that. You can initiate the answer in those 30 seconds. Is when somebody says that I am healthy, or when somebody talks about health, what is the meaning of that? Anyone can answer, please.
May I?
Yes, please.
Yeah, I think it means that we are physically, mentally, spiritually feeling good. It's a well-being feeling, which is very positive, and we remain active as well as happy and sort of creative. And it's a holistic, integrated concept.
I'm very happy to hear that, though I was not expecting that probably somebody would be answering that way. I would like to tell the audience, see, what normally people feel is that a state of physical well-being, like you are not having any medicines, you are not having any disease, you're not having any problems, that is the state when you say that you are healthy. Well, that is right to some extent. But like what ma'am said, that there are three important components. One is state of physical well-being, there is a mental well-being, and there is a social well-being. So there are three main verticals, which probably we do not realize, we do not know. Today we are going to talk about the mental or the psychological well-being. We take so many medicines, we take so many treatments for various diseases that we are suffering from, maybe heart disease, maybe diabetes, blood pressure, whatever and what and what not. But have we ever thought that what about our psychological health? Has anyone ever thought about that? Probably it never comes in our mind because we don't feel so. It is now medically proven that psychological health has a direct impact on our physical health. If we have psychological issues, somewhere or the other, it does affect our physical health. Now you will be wondering that what is wrong? Where do the things go wrong? We are living a comfortable life. Where is the problem? What is affecting our psychology? See, what happens is throughout our life, we face a lot of situations of emotions, various emotions. Emotions can be of happiness, they could be of depression, they could be of sadness, loss of a separation from somebody, and very important and the most commonly is the stress factor. We face stress day in and day out. We face stress when we are young, because we have to work, we have to take care of our children. When the children grow up, then the stress comes to get them educated. When that happens, then we feel that then get settled down, and so on and so forth. Stress never ends. It's just one stress replaces the other stress. So we face a lot of these situations which we are not aware of and which can affect our psychological and our mental health, and directly or indirectly over a period of time it affects our physical health. So now what is to be done? So today, to discuss about this, we have invited a very, very senior professor, Professor Dr. Nimesh Desai. He is a very, very senior psychiatrist having more than 40 plus years of experience. A person who has remained as a director and a professor and a head of department of prestigious institutes like NIMHANS in Bangalore, All India Institute of Medical Sciences in Delhi, and many more institutes. If I keep on speaking up, when I got his detail, if I start speaking about that, I will take another half an hour. But a person who has had many national and international certifications, many fellowships of various societies, a fellow of Royal College of Psychiatry of UK. As I said, if I keep on speaking, it will take too long. So Welcome, Dr. Desai. Thank you very much. It's a pleasure and a matter of honor for us to have you here today. And my request to the audience today is to kindly listen to him very carefully, because he is a person who has got a lot of knowledge, experience about psychological wellness, especially for the elderly. And please feel free to ask any questions. That is more important, because that is how the interaction will be complete. So do ask questions and do listen to him intently. Thank you so much. Over to you, Dr. Desai.
Okay. Good evening, all of you, and Dr. Aman Khera and the group. Really, thank you so much. I'm always so impressed by many such individuals and organizations like yours in different areas that you keep working. But since we might be a short of time, let me cut through those formalities. A sincere thanks for having me here. Let me bring right to the table two things that I had resolved for bring up toward the end. But because of a very important and sensitive query that you brought out, Dr. Aman, and the two things that I want to bring up are these. Yes, I have much less than my friend Mala, but I have had some international exposure, and yet I'm not a great unabashedly. I'm not a WHO UN guy. Having had that disqualifier, I have had a huge conceptual issue with the WHO's definition of health that Mala referred to indirectly in her wish list for what would be psychological well-being. And for those of us who may not remember, although I think there'll be very few, please recall, in 1974, the WHO headquarters put out a definition of health that was kind of endured. And now it's going to be nearly 50 years, in 2 years from now. It's endured with some additions that people have made. Health is not only absence of disease, but a sense of well-being, physical, mental, social, and of course, people from India and other countries added spiritual later. My serious reservation about this definition for last 2 decades or more, and increasingly so, is from individual, personal, and family experience, from clinical work, and from the community field work. So it's very fine to say health is a positive state of well-being. I forgot to say that. Not just absence of disease, but positive state of well-being. And that's where the problem begins. As we all realize for our own selves and for our parents and for our elders and patients and their families, beginning 40s and 50s, and certainly by the 60s and 70s of life cycle, there are very few people who do not have any physical or mental health problem. Okay? There will always be a transient, short-term or a long-term, if not lifelong, physical or mental health problem that people will have. And if you expand that disease idea to disability, almost everyone in old age will have one or the other disease or disability that he or she is carrying. So the problem with the WHO definition, and this is very direct relevance to what Dr. Aman Khera started with. Please get out of the idea, if you can, believe me, health or well-being is not about absence of disease. It is about living with a disease or a disability. That ability to live with a disease or disability and yet be positive in thought, yet be feeling well. So as I've written in Business World once or twice, this antagonistic use of the two words illness and wellness is a serious problem. So anybody and everybody who has any disease or disability condition immediately begins to feel that now I cannot be well. Well-being is impossible if you have a disease or disability. I say with all respect, nonsense BS. The first thing. Two, if there is anything that old age teaches us humans, again at every level, individual experience, family, science, it is what Dr. Aman Khera was highlighting, again, very well. The fact that physical and mental health are not only dependent on each other, but actually are two sides of the same coin is best proven in old age, maybe not when one is 18 or 25 or 32 or 47. But by the time you reach 50 or 55 or your parents reach that age, you realize that physical and mental health are essentially two sides of the same coin. And so those two major points that I want to make, one about illness and wellness, and please get out of that idea of absence of disease being a precondition for being well. To deal with, to live with, and to live positively with any disease or disability is possibly the crux of living beyond 65, 70, definitely beyond 75 or 80 or 85. Having made those 2 points, let's come to, I'm going to have my remarks in 2 major parts, my friends, if you'll please be with me. One, what are global, world over, some science or social science and health science findings that may be relevant? And 2, then contextualize that to India, if not South Asia, the culture and the socio-cultural milieu. Now, there are some characteristics of old age that I'm going to recap, and that's relevant to psychological well-being. If there is one reality about the age beyond 60 or 65 or 70 or 75, and certainly over 75 or 80, it is not only disability that I referred to, but what I learned in theory and I'm now learning in many ways practically, with family, with oneself, with friends, is decreasing abilities. There need not be the benchmark 40% disability. But as age advances, decreasing ability for vision, for hearing, for locomotion, for simple movements of life, of kitchen or household work, or merely picking up your glasses and wearing them and reading a newspaper. So one reality of the elderly existence is decreasing abilities. And my sense from clinical and social experiences, that's one difficulty that most elderly do not come to terms with, nor does the society help them in a supportive manner to come to terms with. Of course, there is a lot of technological advance. There's a lot of assistive devices that help stem that process of decreasing ability. And yet, decreasing abilities in all the 5 senses, if not beyond those 5 senses, is a harsh reality. Let me share with you, my colleagues are here, some of the disability and mental health rights activists also, Madhu Juneja and a few others. Let me share with you one of the lessons that I've learned from the disability sector in last 2 or 3 decades related to decreasing abilities. There is no point the society identifying X person, 10 or 15 or 22 or 40 persons in the society or in any age group as being disabled or with disability. While people with disability is a progressive term and concept like Divyangjan, that makes the serious error of dividing people into abled and disabled. The lesson that I have learned from one of our friends in activism field, disability activism, is we are all temporarily able. There is none of us in all the human history who has been permanently through life course totally able. I'm going to go out on a limb and say that. So please realize, and this realization happens only in old age, for oneself and for children who look after the parents or the carers. So ability or lack of ability or disability is a continuum, is a spectrum, and that keeps affecting in old age much worse. The second, as you all realize, is not just the social isolation, but the psychological sense of not being worth, not being relevant, not being useful, as we all realize. The third and the harsh reality is also the decreasing economic power. Now, I realize that, the group that Dr. Aman Khera's initiative deals with, and those of us who are collected here, might be a tad or more than a tad lucky about economics. But many people are not. And even for those who are economically well provided for, the relative decrease in economic affordability raises an issue. And I must say here, tongue-in-cheek, that while Bagban was a great movie, not every life story is Bhagwan. Not everyone gets that multi-million-dollar contract for a book that he writes. So like many other films, unfortunately, in trying to make a happy ending, positively ending film, the whole story to my mind goes haywire in the latter part for wider dissemination. Because most people do not have that luck. Very few do. The other thing that I seriously want to put across to all of you, and all of you are experienced in different ways, and I'm going to come to that in a minute, is this whole issue of, and the adage and the push of slightly the American or the Western style, you are as old as you feel. Sure, well-being and your status of health and everything else will depend on your attitude and positive constructive thought process. But accepting the realities of whatever age you are at, including decreasing abilities and including what you can do and what you can't do, is a very important part of well-being in old age. So please try and be careful for oneself or for your parents or whoever else one is involved with, not to carry that notion of positive nature too far. Let me quickly, briefly come to what are the important Indian South Asian cultural contexts. Doubtless, the much celebrated joint family system, although now undergoing a rapid transformation for last few decades, is still much better and well worth all the negatives it might bring for many aspects, especially care for the elderly. Having said that, let's also accept that, like it is being recognized in social sciences and social sciences related to health, I think much more clearly than it was, let's not believe blindly that all joint families are all very positive and nice. Joint families have serious problems, including the issue of elderly care. And so there is, besides the transformation that the society is undergoing, there is a need to be cautious about the benefits of joint family. And yet, doubtless to say, the way we all function, even if we are located across cities or countries, as Indians or people from South Asian culture, decidedly have a huge advantage of, besides our basic values for care and reaching out and whatever else. There is, of course, what elders in some cultures, like Afro-Asian cultures, carry as resilience. And there is, I think, enough evidence across conditions, across situations, that psychological resilience or psychobiological resilience is very culturally dependent. And so those are the advantages that we have. The trouble, I think, is this, and this is again a larger generic issue for all marginalized groups or all need-based groups for social action. And that is, although we are beginning to accept and act, we are not, I think, doing it very well or deep enough or broad enough still, that our society is rapidly changing. And so, like many other groups, the elderly in India fall between the two stools, so to say. The traditional values and benefits that accrued to the elderly earlier is beginning to decline and doesn't accrue too often. And yet the official systems by the government or by government-sponsored NGO sector, which should be available, are not available in as robust a strong manner as they should be or as they are in US or UK. And so, like everything else, in India, what happens is we are kind of neither here nor there in the transitional phase of our society. And that's the other thing that we need to really recognize and work for. Can I also briefly mention, and I really like everybody's, or at least some people's views on that, the 4 ashramas as described, especially Vanaprastha and Sannyasa, in the 21st century require slight redefinition, not just in terms of calibrating the cutoff points. I mean, should Vanaprastha begin at 60 or at 70 or 75? Should sannyas ashram begin at what age? But in addition to that, and I think our Shastras said that, we may not understand it too well, the dynamic, confluent nature of the last two, especially, if not all four ashramas, and to what extent do we really follow that? I'd really like views on that. Can I say here one idea that my friend from mental health activism field, Madhu Juneja, will possibly elaborate on better, and maybe other people from other sectors. Please be sure that some of us, in different ways, from my friend Mala Kapoor Shankar Das, with her tremendous expertise in social sciences, in gerontology and health and well-being, to psychiatry or any of the other experts that you have got, with all respect, bring in only the technical expertise. And the field of activism has now begun to not only recognize the two parallel or confluent streams, but also the need for integrating those. The technical expertise and the lived-in expertise. And so all the elderly who are with us here today, and many, many millions who are not here with us, I think we need to begin to recognize the lived-in expertise or the experience, both of the concerned persons, and from what I understand about Aman Khera's work, your organization, the carers, the family-based carers, the paid, untrained volunteer carers, or paid trained volunteer carers. The whole spectrum of carers. What's the experience and the expertise that this different groups have? And to me, it seems, and if I'm mistaken, please correct me, any one of you, I don't think there is even minimal documentation about lived-in experience or lived-in expertise of either the elderly or the carers for the elderly, as much as it should be. And both science as well as the governmental action and social policy can benefit hugely from the documentation and the dissemination of that expertise. Does any one of us know? I recently read on the social media and a few other platforms this whole idea of what has been known in our joint families, what's been tried in Japan as experiments, family-based or NGO-based or official system-based merging or synchronization of the care for the elderly and care for children who need to be looked after. The word orphan children is a pejorative, loaded term by now. But in the epidemic, again, we have learned among the many lessons that there needs to be special action for children who have lost their parents, one or both. So children without parents, children without family support, and the elderly without family support. To me, the more and more I think about it in the last few weeks, and triggered by Dr. Aman Khera's invitation and our dialogues, it seems to me that that's a huge untapped potential. Integrating and synthesizing the care models for the elderly with the care models for children. That is something that really could bring so much benefit.
You have really put up a very interesting point about the joint families and the current trends, and of course the separation because of COVID or whatever the thing is. So one question that comes in our mind is that there are so many elderly who are actually staying alone because the children are now going migrating from one state to the other, one country to the other, and so they, of course, all the parents want their children to prosper and to progress. But eventually, somewhere or the other, staying alone does affect their psychology, or maybe they add to some stress. What do you suggest about that, and what do you say about that? How could that be, taken care of or managed, at least by the elderly themselves?
Sure. That thank you. That's a good point. Also, in the context of the epidemic and what it did, more accentuated. But if I got you right, okay, let me flag something else before I come to that. I had it in my mind. this whole idea of care for parents that you seem to focus on so well, I've been thinking there was a time when the carers would have been typically seen to be people in their 30s or 40s or at best 50s, looking after their parents in the 60s or 70s, right? I think with the demographic change and a whole lot of other changes, even that is getting transformed. By now, the carers are in their 60s and 70s, and the elderly being cared for are actually in their 80s or 90s. So that shift that seems to have happened across the board. Now, that in the context of what you're saying, sometimes the carers themselves might be in the group of not so old, 65 to 70 or 75. And so loneliness is an issue, or the social isolation is an issue, I think, for both the groups. And so if at all there is a logistic, practical solution to that within the city or across cities, if not countries, sure, as the best possible solution. But the major point that I want to make, Daksab, is this. And my learning among the thousands of other things that I learned and many of us learned in the epidemic is that the elderly as well as the carers, even if they happen to be advanced in age, but the elderly certainly, those who can take good advantage of the technology, especially the phone and the apps and social media, because there is no point looking for the ideal of what used to be. The interpersonal contact merely by audio calls, preferably by video calls, through social media, can be a huge mitigating point, as I think it was during the epidemic for all age groups and certainly for the care for the elderly. Surely, as I said earlier, with the decreasing abilities, visual or hearing or others, there is also genuine limitation to what extent the elderly can use all these gadgets and the technology. But like I said, with assistive devices and with more of openness to using it. I mean, we all know of the elderly who would possibly have resistance to use of technology. So my major appeal, if I might crystallize it, is that all of us here need to really spread this idea that embrace the technology rather than lambasting it and regretting what does human existence come to. We used to meet in person and have a meal and share and pat each other's back. If that's not happening too much for whatever reasons, it's not happening. So I would really think that helping the elderly and the carers embrace technology meaningfully is one good idea, sir. What do you think?
I think what you said is a very, very interesting and a interesting point, and which is relevant to the current times. Because whether we like it or not, the concept of nuclear families is coming in, and the world is becoming smaller because people are going from one country to another, traveling at the drop of the hat and going for jobs and work. And this is eventually going to increase, and definitely the elderly are going to be eventually left back at home, or maybe in isolation, or maybe. So technology today definitely is helping connecting the people and making the world still smaller. So yes, times are gone which were 20 years back, 30 years back, when you had to wait for hours for a trunk call to be booked and talk to near and dear ones staying in the other country. Today, at the click of a button at no cost, we
and
can.
I dare say, sorry, I dare say that like we have the audio and the visual senses now possible.
Yes.
Soon there is going to be, I believe, tactile and gustatory possible.
Hopefully, yes. Hopefully, yes.
Technology is,
So for the audience, I would like to say that staying away from children today, yes, it does have an effect sometimes, but we should be thankful that technology is now helping us to connect to anyone and everyone, anytime and every time. So that is one of the very important things to be mentioned. Another thing which Dr. Desai, I was having in my mind, like as you were speaking, is that which you also mentioned was about physical disability. Now, physical disability does have an impact on the psychology of the elderly, or rather, actually, it can happen to anybody. in younger people also. And at times people, like for example, who have had a stroke or maybe who have had a heart disease and have a limitation in their mobility or in their working capacity. So how do you suggest that? How to tackle those situations? Because the mental activity is there. The person wants to work, he can work, but the physical disability restricts the person's movement, and that can have a great impact. So, what do you suggest about that?
I would say there are at least two legs that I see to that stool of need, if not three. One, again, like we said about technology, here also that's relevant. I think a lot of us, if not the other generation older to us, across the globe and certainly in our parts of the world, seem to have this technologies. And so one is, if we can help the elders overcome all that and try and use technological expertise and assistive devices available for that disability or decreasing ability, hear or visual or whatever, not I think the data is, and you might correct me or anyone else, the utilization of available hearing devices in our country is still very, very low. So that whole spectrum of helping the elderly accept and use the technology and the assistive devices available. On the other hand, it might seem contradictory, but to me, it's not. Where none of it is possible, acceptance of the decreasing ability or disability.
Yes.
That acceptance, those are the two legs that I was talking about. And the third is, of course, volunteer, family-based or paid trained assistive workers based human assistance available for taking care of those decreasing abilities. In fact, let me share an example in quick minute. I have an elder cousin. This ring that I'm wearing is only him. He was about 25 years senior to me, one of my elder cousins, and we lost him some years ago. Now, he used to tell us very interesting stuff. He said, when we were young, and when we would come back home in the middle of the night after a theater play or a movie, and you knock the door, and his mother, my Fufi, would take quite a few minutes to walk up to the main door and open it. This cousin of mine would say, "Yaar, I used to get so irritated about why the hell does it take you so long? We are waiting outside there." And when he grew to be in his 70s and 80s, he said, "Now I understand what my mom used to go through." The trouble with old age, sir, and that's where in our society it's been happening, but we need to perhaps do it much more. If I might say in a lighter but serious note, a lot of wisdom about living well or being, well-being, you learn by the time it's too late to apply. So if at all we could transmit that to younger generations,
very
आपको समझ आती है, लेट हो चुका होता है.
I think that's a very, very valid thing you have said, that when you realize the time is too late.
हाँ, तो वो गैप कहीं फिलअप कर सके हम,
So that's very interesting. So Dr. Desai, one more thing that came in my mind.
Sir.
In last 2-3 years, we have seen such times which probably have, at least in our history and medical history as well as history, we have never seen, and that was the COVID times.
Mm-hmm.
And do you feel from your experience that the psychological impacts of COVID, are they still present? Are they still living on the elderly? What do you think about that?
Good question, sir. Can I answer that in two parts? And one that I'm going to use your question to, as I was hoping to use it for. I don't know if you or some of the other colleagues, I'm sure Mala Kapoor, Shankar Das knows this, and a few others. About 20 or 30 years ago, I came across very robust American evidence about depressive symptoms and depression as a syndrome. And I hope I'll be able to explain this without the slide. What the Americans found, even for their society, and I think it was more true for our society, even now, is that the percentage of elderly with depressive symptoms was about the same, about 30 or 32, 33% in elderly living at home with families and elderly living in institutions. Okay. So depressive symptoms are about the same rate wherever you are living. When you come to depressive syndrome, the rates are very differential. For people living in institutions, the rate of depressive syndrome was about 12 to 14%. And for people living with families, only between 2 to 4%. So the point that I have understood from that, and I keep revising this to myself, is to some extent what may be called in science the depressive symptoms. I individually think we should not even call them depressive symptoms. They are normal experiences of living in the elder stage. They are quite common. But if the social support systems and the living conditions and the psychological attitude are favorable, depressive syndrome will be much less for people living in families as compared to people living in the institutions. Now, I'm going to connect that to what you said. My sense, Daksa, is this. All age groups did, and certainly the elderly, I think, did much better than almost anyone expected in the epidemic and the lockdown period. Like I referred to earlier, the resilience, human resilience across the globe, and surely human resilience in cultures like South Asia is much more robust than one could imagine. And so, to put it differently, you must have heard, a lot of other people must have heard that after the epidemic, there is a psychiatric epidemic coming up, or it's already come up. I really don't think so. Not psychiatric epidemic. Epidemic of psychological distress? Yes, possibly. So I'm differentiating between psychological issues or issues of, not feeling too well, having negative impact, to psychiatric disorder. Fortunately, human resilience in general, to repeat myself, and certainly South Asian context, is still pretty good if we can utilize it well to not lead to major psychiatric issues. I also think that, and maybe I'm dreaming here or seeing it unduly positively, but all cultures, and certainly our culture, I think mostly, except for problem areas and pockets, it brought out the best. So within families, within neighborhoods, within societies, the kind of support that came up for the elderly, for the disadvantaged, was actually pretty good. My third and last point in that series, I differentiate between two issues of post-COVID. For the society or from public health viewpoint, post-COVID is still undecided, and maybe we are still in the last few curves of the epidemic. Okay. But for individual post-COVID syndrome, those who have been through COVID infection once or twice and might have clinical syndromes or symptoms related to individual brain, mind, body systems, individual post-COVID syndromes is a harsh reality. And let's face it, all of us in medicine or healthcare, including the social care sector, are still only learning that part of the science. So pulmonologists to cardiologists to psychiatrists to now rheumatologists, we are all diabetologists. We are all learning what all can happen to individuals in the post-COVID phase. And so their caution is the better part of the valor, especially for the elderly, those who have been through COVID infection once or twice. Whatever symptoms, unusual or new, that one has, please get it examined, please get it screened, because it might be one of the post-COVID symptoms or syndromes.
So we have a question also, that how should the children recognize that if there are any psychological issues elderly are facing after COVID?
See, this is again, I mean, as we all know, I'm sure I'm going to be saying something that you all know too well. We all try and practice it in different ways and yet not able to do. Within families living together, parents and children as carers, or across different households in neighborhood or within the same city, or across cities or across the nation, as you said. If there is one thing that the elderly require and want, and that unfortunately most of us at the peak of our careers are not able to provide and not inclined to provide, is a listening ear. All that, those 5 or 10 minutes or 15 minutes while going to work in the morning or after coming back home from work or over a weekend, time, if possible, quality time, and that sense of safety and security. So the best thing, preventive for children to do is this. Can I also say this? And I think this will bring me to the other thing that I had in mind to bring up. Adult or young adult carers. Again, I'll keep repeating, family-based, volunteer, or paid. We all need to remember that when it comes to persons in the elderly age group, especially over 75, 80, it's common, as I said. And let me break one more myth. Science believed 20 or 30 years ago that suicide don't happen in the elderly or suicide behavior. We know it does. And so look for depressive symptoms. Look for suicidal ideas if you get. Take every suicidal expression very seriously. Now that's a bit of a thin ice that I'm talking about. Because like I said earlier, and we all, I think, recognize, in old age, some psychological or physical experiences which may mimic depressive symptoms is already part of the order. Within that, we want the carers to be able to pick up if there is an accentuation of any symptom. So the common, if not usual, negative thought or the romanticizing of the past or whatever cognitive thinking issues that happen in old age, within that, if there is a sharp edge, if there is an accentuation, most importantly, like it is true for psychiatry, that's up, and let me enunciate that principle for half a minute or minute. The important part for recognizing psychiatric syndromes at any time, and certainly in old age included, would be, is there any recent significant change? So if one has a parent, at 85 or 88, and I have known the parent obviously for 10 or 15, if not 30 or 50 years, for whatever last 10 or 15 years, is there a recent change that I see? Recent significant change is by and large one good indicator of the need for screening for psychiatric syndromes. If that makes sense.
No, I think that's a very important thing what you said, because it's for the children primarily, the family caretakers, as you say, who can actually recognize if there is a change, a recent change in their behavior or in their, day-to-day, whatever. So that is an indication, and that should be taken as a, let's say a warning sign or something that some sort of an intervention or a help is required, which probably sometimes people tend to ignore.
Yes.
As an age-related change in behavior, or maybe maybe a temperamental change, but
Yes.
that the people tend to ignore. That is the very important thing.
Yes, sir. The second part that you said is actually very helpful. Yes. Can I also just say in one sentence that as you and other friends must have realized, I have kind of stepped away from my medical doctor psychiatry identity and not talked about that too much. If you would like, you can elaborate on that. But the whole issue of psychiatric syndromes in the elderly, dementia, mild cognitive impairment, depression, is one set of issues, But since you and I had agreed to talk about psychological well-being,
So one more thing, which was coming in my mind, which is a harsh reality, is when somebody loses a partner, lot of impact takes place on the psychology of the person at that time, whether or not the person is staying alone or with the kids. So what do you suggest that what should be the way forward? Because that's a harsh reality, nobody can change that.
Yeah, there are two things I'm going to say to that, sir. One, and again, I hope I don't offend sensitivities, or if there are please feel free, any one of us. But I really think that popular film, popular cinema, and television serials, much as we might lambast them at some levels, are not only good indicators of social change, but very often they're also harbingers of social change. They can trigger social change. And sir, I'm referring to that issue when two people in the elderly age group, with or without children, want to come together and get married, which in our culture was almost taboo and unheard of, right? For whatever good reasons in historical past. By now, in the 21st century reality, I really think if that's feasible and it happens, I think we should really become more and more open to that idea. That's one thought that I have. This whole issue of, living in old age in penance or पुण्य जमा करने के लिए और अकेले रह के और तकलीफ सहन करके is perhaps worth reviewing. The second part is this. Acceptance of isolation, if I might say, and please don't get me wrong here, I have learned only after I crystallized that to myself and through whatever, my own parents are going through. I lost my dad some years ago. My mom is still around in Ahmedabad. That important aspect that Bhagavad Gita makes very well, I am told, and I'm no expert on that, is the difference between loneliness and solitude, akelapan and ekant. And the second, I don't think Bhagavad Gita talks about that too much, but with all respect, maybe I'm mistaken. What I am learning and I'm trying with clients who I see or families is the ability to convert loneliness to solitude. उस अकेलेपन को अगर हम pleasant एकांत में बदल सकें, with one's own help, with people who can help, the third point that I just thought of, and I don't know if my friend had said he'll be here, our good friend Bobby Grewal, but talking once to Bobby Grewal's groups a couple of weeks or months ago, I had also mentioned that in last 1 or 2 years, and maybe as a function of my own growth with age or otherwise, I have had clients and I'm now formalizing what I think is a gap in the whole field of counseling and psychotherapy. Counseling, Madhu, you might again tell us better. Counseling perhaps had some effort, but the technical field of psychotherapy has usually just not focused on models of psychotherapy either for the elderly or preparing for old age.
Absolutely.
So people in their 50s or early or mid 60s, not only when they come to any one of us for psychiatric syndrome that we start talking about, but I am beginning to and hoping to develop and put forth counseling or psychotherapy modules for both people who are already in the elderly age group and preparing people before that for old age.
That's very interesting to hear that you are trying to manage the people who are in the elderly age group as well as those who are entering into the elderly age group and getting used to that. I think that's very interesting.
Dr. Desai, I've heard you many times, and you have always tried to build confidence in people to deal with their mental health issues. You have tried to empower them. So in that context, can you give 3 tips which would help older people or those aging to relate well with their children so that care by children becomes easy?
Like every other aspect of life and old age, certainly psychological well-being is a matter of acceptance of the reality. Acceptance of the reality in every sense, the physical, the economic, the social, the emotional. Can I, as a tangent, mention also, and I'm going to come back to bullet point 2, and I don't know, Aman Ji, if this has come up anytime in the earlier discussions, But one block to that acceptance of the reality in old age for psychological well-being is again a reasonably common psychological phenomenon. And so it's good to guard against that. Romanticizing the past is a common human tendency, almost universal in old age. हमारे वक्त में बहुत अच्छा था, हमारे वक्त में ये होता था, तब ऐसा नहीं होता था. Okay, so what I'm putting on the table for everyone to consider, for the elderly to try and do it on their own, and for the carers to try and kind of keep it in mind and still help the elderly overcome that barrier or block, because it's very satisfying, it's very gratifying to say वो वक्त बहुत अच्छा था, अब तो समाज बिगड़ गया है, ये हो गया है, values खराब हो गई हैं. So that whole pitfall will be good to avoid for acceptance. The second, if I might say, Nala, is again what we have touched upon. I really think that the resistance and the difficulty in using technology or available resources. Can I say again, go out on a limb and say that, and that's true for oneself also. And I've worked through this psychologically, believe you me, within myself. Like Dr. Aman was saying, when in my generation, some of our generations, people used to migrate across towns and cities in the country, much less. By now, it's much more. And so the proportion of elderly parents living in one town or city and the children, daughter or son with in-laws living in a different area, much more common now. Ever so often, the elderly will find much more meaningful emotional, social, and other logistic support in people other than their sons and daughters. The nephew or दूर का रिश्तेदार or the neighbor or somebody else who just happened to be earlier a social acquaintance. And I'm saying this because sometimes my sense from a variety of experiences is that sons and daughters in their adult age group actually often mess this up. They can't be there. Like I couldn't be there for my parents in last 20 or 30 years or whatever that I kept moving across cities and in Delhi. Am I comfortable to cooperate with those, again, paid or unpaid, socially volunteering or other carers who are available for them? Can I synchronize my effort with what they are doing rather than letting it clash? You see, this is a very unconscious process that, मेरे parents हैं, मैं care करूंगा यार, तुम क्यों बीच में आ रहे हो? अरे यार, आप तो कर नहीं पाते हो, जो वहाँ local कर रहा है वो करे. And elderly are generally, I think, very happy and satisfied to depend on locally available support system. Yes, emotionally, it would be nice if the children or the grandchildren could be there, but possibly not. And so I'll break that into 2 bullet points. 1, acceptance. 2, use of technology and all the assistive devices and help. 3, in our own mind, the carers and the elders both need to perhaps recalibrate the idea of support systems for the elderly. In our traditional society, this whole idea of going to an old age institution or group living for the elderly was considered such a heresy. It need not be. Can we collectively review our social care models to say if that is one of the better models in that situation, so be it. That requires a very different working group.
I'm happy.
You're about to say something, Aman.
Mention that because that was going to be my next question, and you've already answered that. I think today has been a great day. We have learned quite a lot from such a senior person like Dr. Desai, and very enriching experience because we are all in all stages of different generations have learned quite a lot. I can not thank you enough, Dr. Desai, for coming up and
Not at all, sir. Thank you.
This such a wonderful discussion. Such a wonderful you have actually touched the right points. What were in my mind also, which eventually we had to figure out. We had to bring it and I'm sure people here will definitely benefit from this. So
Thank you everyone, sir. Amanji Khaskar.
Thank you everyone. Thank you for joining, and thank you very much, Dr. Desai, for giving us time and your
So great. Anytime.
Thank you everyone.
Wonderful, sir. Thanks.
Bye.
Bye. Good night.